All right, so it's 2:01. I don't think I've seen it. Yeah, a couple more actually came in, but I'll go ahead and get started. My name is Heather Saffel. I'm currently at Notre Dame in South Bend, working at Beacon Medical System as a sports medicine physician and associated with the fellowship here. But I was a former fellow representative from Emory. That's how I got on the subcommittee. We're going to have Dr. Steven Simons talking about the pediatric spine today, and I'll introduce him and talk a little bit more about him in a couple slides. There's a little lag in my clicking. There we go. So this is the National Fellow Online Lecture Series presented by the Education Fellowship Committees. And this is to serve as an adjunct to your individual programs, educational programming. We have experienced AMSSM members sharing their knowledge and experience with us all. We're lucky to have them. And this is to help with CAQ exam preparation. All of your devices already will be muted. Please submit any questions in the chat. We'll do our best to answer all of them at the end. And if you feel comfortable, you could say them out loud as well. And then we may or may not have evaluations for you to fill out at the end. I don't think we have that quite ready for this year yet. But let me go ahead and introduce Dr. Simons. He is currently the Director Emeritus at South Bend Notre Dame Fellowship in South Bend, Indiana. He is on his way into retirement. Not yet, we're lucky to have him, and I hope he stays with us as long as possible. But he also is a team physician for the University of Notre Dame, working specifically with cross country and track and field. He's also helped with the USOC, helping with the Pan American Games in 2003 and the Olympics 2004 for the track and field teams. He's helped author several chapters in books. He's active on UpToDate, having several sports medicine topics. He's provided a lot of research experience. And he actually gave a lecture at an AMSSM conference before on to brace or not to brace versus Stan Herring, who's another expert on this topic. So I'm excited to hear his knowledge regarding pediatric spine. So without further ado, I'll let Dr. Simons take it away.
Okay, thank you, Heather. And also thank the AMSSM for doing this, and you in particular, and allowing me to participate as well. And I was asked to give this session on pediatric spine. As a word of warning, I have not practiced this, so I'm not sure of the timing. If you're following along, I think I have 95 slides, roughly 96 maybe. So you can help me stay on track and see if we can get through all those slides in the time allotted. So off we go with the pediatric spine. And why? Okay, I had to click and my arrows didn't work. Couple of goals and objectives as usual: discuss common spine back conditions in the pediatric population, both diagnosis and management, and introduce a few uncommon conditions for which the sports medicine physician should be aware. Now, I'm going to first just mention things that we're not going to go. You know, what direction are we going to go with this, and where we're not going to go today. We're not going to cover certain things like cervical stenosis, traumatic injuries to the spine, spinal cord injury, disc herniations, and discitis. I am going to mention a couple of spinal tumors, however, so I'm not going to focus on that. So first, to start off with a case, this was one of our cases in the office a few years ago, child of a X-ray tech at our hospital. 11-year-old, he was visiting relatives in Indianapolis, stumbled down some stairs and developed some neck pain. So the mom took him to the ER, had X-rays, and was told the X-rays were normal. But because she was a X-ray tech in our department, she brought the films back home for another opinion with our radiologist, and that radiologist had a different opinion from the original reading radiologist. In a regular lecture hall, this would be the point when I would ask for audience participation and what do you see? So since that's not possible, we have to go directly on to the diagnosis. This is one of those conditions that I think all sports physicians should be aware of, and that's a Klippel-Feil Syndrome. First described in 1912 by Maurice Klippel and Andre Feil. These youngsters in a classic setting have short web neck, they have decreased range of motion, and a low hairline. On X-ray, they're classified in different ways. There's the classical system here and a Samartzis classification. Type 1 is a massive fusion of the cervical spine. Type 2 is fusion of 1 or 2, which is what we see most of the time. And type 3 is the presence of thoracic and lumbar spine anomalies. And this is this is what you might see in a classic case in a child. However, in our adolescent population, they may not be so obvious. The incidence varies depending on what kind of studies were used to make the diagnosis, whether they were actually incident studies based on skeletons or whether they were X-rays or MRI CT studies. But that incidence is estimated to be about between 0.02% and 0.58% of the population. A presentation is most commonly going to be noted as a decreased range of motion. They may be seen as an incidental finding. X-ray is done for some other reason, particularly in contact sport, and then the fusion is noted incidentally, and it was heretofore not known about. There may be hearing loss in about a third of these individuals. There's also other associations that could be possible: instability, scoliosis, maybe a Sprengel anomaly, and numerous other anomalies. For the workup, you usually start with a plain radiograph, C-spine, and consider flexion and extension phelps. Because of the fusion, the adjacent levels may show signs of instability, like you see here on these extension and flexion films. You may consider X-raying the entire spine, thoracic and lumbar, to look for other anomalies. You may consider a rib series. For those that are considered for surgery, a CT scan is necessary, and you may consider MRI for looking if there are neurosymptoms, and ultrasound of the kidneys if any concern about anomalous renal function. The big thing for us is should these people participate in sport, and so this is where just some modest knowledge of this condition is important in determining who can participate in sport. So for type 1 lesions, there's absolute contraindication. For type 2 lesions, if there's a limited range of motion, C2 involvement, instability, spondylolysis, or other occipital cervical anomalies, they're also absolutely contraindicated. There's a relative contraindication if they have type 2 lesion with a known previous episode of transient quadriplegia. Those who have type 3, usually a single fusion located below C3 with full range of the neck and lack of instability or spondylosis, may participate in sport with proper education and measures. So this is an important distinction, is what level this is at. I've had a couple of cases where they've been identified. One was the X-ray shown, another approximately 12-year-old football player, big young bruiser of a character, where this was picked up. And so his entire, he was a type 2 lesion above C3. So his entire life athletic career was changed as a result of that X-ray. On to another cervical issue. I've got one of my own cases, an 18-year-old Division I cross-country track athlete, not often thought of as having neck problems, but she develops lower cervical neck pain after a weight training session and a swim workout. Nothing dramatic, just developed this pain. No neurologic symptoms, had tenderness to the mid-lower cervical spine. And after a period of watchful waiting, proceeded with imaging. And so she very oddly had a traumatic clay shoveler's fracture, or rather a non-traumatic clay shoveler's fracture, shown by this CT. We just had this case published in Current Sports this past fall, or winter rather. And the chief issue here was why would this athlete develop such a fracture? And it was because she, at 18 years old, had a DEXA Z-score of minus 0.3.3. Incidentally, she had a twin sister that also, but however, had no injuries and still has no injuries with a DEXA of -4.3. So an incident, a rare problem of having an odd fracture, probably due to Red S syndrome. So I wanted to bring that up because there is a pediatric equivalent to Klippel-Feil fracture published in Spine 2012. And this is not a fracture, but just a spinous soft tissue avulsions with a lot of flexibility in the neck, perhaps some dramatic flexion, trauma event. There can be enough spinous process widening to create soft tissue avulsions at the spinous process. So this is referred to as the Klippel-Feil fracture equivalent in children, but simply a soft tissue, not bony. Going to move on down the spine. Next is an 18-year-old freshman presented with chronic thoracic back pain. Pain had been there for over a year, entire senior year of high school. He had minimal pain at rest, was worsened with prolonged sitting and after more intense training sessions. He had previously been evaluated in high school, including an X-ray by chiropractors with no specific diagnosis. On exam, he had a little mild to moderate thoracic kyphosis. So again, we're looking for audience participation. What's your diagnosis? And the diagnosis is a Scheuermann's kyphosis. Scheuermann's is diagnosed by having at least 5 degrees of anterior wedging of 3 consecutive vertebrae. This is going to lead to an increased lordosis. This picture may be hidden by the, I should have been aware of that, hidden by the on-screen videos, but this man here is leaning over a very prominent thoracic spine. In a normal, there's a normal kyphosis based on lateral x-rays with the arms extended. It should be 22 to 51 degrees in 5 to 9 years old, only a little bit increase to 55 degrees as you get into the teenage years. With this particular condition, the problem is a premature closure of the anterior physis. So it's thought probably due to the fact that in the thoracic vertebrae, the cross-sectional axial anatomy is such that it's triangular. It's narrow anteriorly compared to posteriorly. So greater forces across the anterior physis in the thoracic vertebrae may lead to premature closure, somewhat similar to physeal closure from overuse to the wrist, perhaps in a gymnast. So the end result is that the posterior physis continues to grow and the anterior closes. So you get this wedging. Again, to make this diagnosis, you need 5 degrees of anterior wedging and 3 consecutive vertebrae. And as with anything, if you're going to identify pathology, it's helpful to be aware of what's normal. So just recently in Spine, Gardner, et cetera, in 2018, had a nice review of what's the normal development of kyphosis and lordosis in the growing spine. And this is an example of the number of degrees of kyphosis and then lumbar lordosis based on age. Overall, there's the kyphosis and lordosis will increase with age. There's not a significant difference between the development of kyphosis between males and females with increasing age. But there is a statistically significant difference in the development of lordosis between males and females, with females having a greater increase in that lordosis. So the males follow this pattern of lordosis, the females have a greater lordosis developing as you get into the later teenage years. So I think this is helpful to have available to just know what is normal when it comes, and parents will often be concerned about various deformities, and it, again, be helpful to be able to tell them what is normal. Most of the time, Scheuermann's is painless, hence my athlete that didn't show up until senior year of high school. They may actually present because of a cosmetic concern. They have a round back appearance that specifically does not reduce with extension. They may have pain associated with repetitive loading. And there's also an association of degree of kyphosis and lumbar lordosis based on time and training. Ashton Miller looked at this and noticed that in a sedentary control of teenagers, the thoracic kyphosis averaged about 16 degrees with a lumbar lordosis of about 70 degrees. Across sports, the worst was gymnastics with an average of thoracic kyphosis of 42 degrees and lumbar of 52 degrees. So you can see there's quite an increase in the risk of increasing kyphosis and lordosis based on the cumulative training time in sport. The management is usually this follows a benign course and doesn't need any specific treatment. Some may recommend a brace for the skeletally immature if that kyphosis is over 50 degrees. And remember, I just said up to about 55 degrees is normal in the later teenager. Surgical management is rare, may be indicated over 75 degrees. Now I'm going to move on to another classic pediatric issue, and that is apophyseal injuries. I'm going to ask you to borrow on your knowledge of Salter fractures and the anatomy of the long bones at typical diathrodial joints. The pediatric spine, you can think of it as a layered cake. The green here represents the disc. Then there's adjacent to the disc is a growth plate. And then between the growth plate and the vertebral body is an osseous end plate. And during the growing years, there's an apophyseal ring, just like you can imagine the secondary ossification center for the ischial or the patellar tuberosity and or the calcaneal tuberosity. So again here, think of this yellow here as the apophyseal ring. So this anatomy is critically important to understand the kind of issues that may develop in the pediatric spine differing from an adult spine. And in specifically is what happens when you increase disc pressure. First, the apophyseal ring will ossify, begins around age 4 to 6, and then will fuse around age 18, probably earlier in girls than the boys. That ring firmly attaches right here. This ring firmly attaches to the annulus fibrosus, or the nucleus of the disc. This osteocartilaginous junction between the vertebral body and the apophyseal ring is weakest. So those things that cause increased discal pressure can herniate the nucleus pulposus. In an adult, we all know that the herniation will find the weakest link, which is posterior lateral in the lumbar spine, leading to foraminal encroachment from that disc. Entirely different story in the adolescent and pre-adolescent spine. In this case, when you increase disc pressure, then the weak spot is going to be the end plate. So instead of typical herniation posterior lateral into the foraminal lateral gutters, the increased pressure will actually fracture through the end plate. So that's what you get with the increased pressure, whether it's sport-related, extreme coughing, sneezing, jumping, etc. You increase disc pressure and you get nucleus herniating through the end plate and into the body of the vertebra above or below. This is then develops your classic Smorl's nodes when that nucleus that disc herniates into the body. And this also will develop, be the reason for a very specific kind of vertebral or X-ray finding, and that is a limbus vertebrae. And this is a typical looking limbus vertebrae that you can see in adolescence, and you will also carry on into adulthood. In this particular case, they almost always occur in the superior anterior end plate in this location. And they're closely related to Smorl's nodes, but in this case, the nucleus herniates anterior and inferiorly and literally lifts off that apophyseal ring right at the level of the disc. So you get this ossified area that's distinct from the rest of the vertebral body. So this is your classic limbus vertebrae. And this is just some, again, a cartoon drawing of what to expect, how this disc herniation creates the Smorls nodes, and varying levels of disc herniations through the end plate and into the vertebral bodies, creating a worsening picture of Smorls nodes. These apophyseal ring fractures and Smorls nodes can usually be treated conservatively with rest, activity modification, non-SEDS or NSAIDs, nothing specific most of the time. Now, I'm going to spend a little time on scoliosis, only because that's your classic pediatric spine issue. I recognize that there may be people on this call that are much more expert about scoliosis than myself. It's not a problem that I see or take care of real frequently. And also that you can easily do hours of education specifically on scoliosis. So I'm only going to touch on a few things just to complete the idea of the fact that this is a classic part of pediatric spine. So the definition is a Cobb angle greater than 10. The direction of the angle is determined by the convexity of the spine. And the epidemiology is such that there's thought to be approximately prevalence of about 3%. And only 10% of that 3% go on to require any kind of treatment, whether it's bracing or surgery. So a really very small percentage of pediatric spine need any specific treatment. There is the male-female incidence is equal, but the risk of progression is greater for the females than for the males. The Cobb angle at presentation is typically worse in adolescents with a higher BMI, probably for obvious reasons. So the etiology is not clear. There may be multiple genetic contributions, hormonal contributions, postural muscle balance contributions, vestibular, just not at all clear. Clinically, truncal asymmetry may be noted by other people, often by parents. They may be picked up by screenings, or it may be simply noted when imaging is performed for some other reason. For instance, if a chest x-ray is performed for a respiratory illness. One has to be, if one notices asymmetry, particularly in shoulder height, be aware of a multitude of other considerations for the etiology of those kind of findings. And much of this section of my lecture here is borrowed from UpToDate. So a nice review of all the other little things to think about when you see spine asymmetry. Now, many times with adolescent idiopathic scoliosis, there are various things you want to know. When was the deformity noted? By whom? Did they have back pain? 23% will complain of pain. 9% had some complete other underlying pathology. Are there any neurologic symptoms? Shortness of breath, perhaps? What's been their growth trajectory? And where they all of a sudden went through a tremendous growth increase. And then, of course, we need to know what puberty staging they are. Simple questions. If menses started, are the boys starting to shave? On exam, your classic things here: asymmetry of the shoulders, scapula, waistline, distance that arms hang from the trunk, for instance. Is there a thoracic or lumbar prominence on Adams forward bend test, which I'll talk in more detail shortly? And is there a noticeable angle of trunk rotation? So this is your classic Adams forward bend test. It is not really that it's not as exacting as you might think. If the Cobb angle is just over 10 degrees, its sensitivity is 74 to 84%, specificity 78 to 93. As you increase the Cobb angle, then your specificity goes up dramatically to 90%, but it's still not completely sensitive. So measuring, especially on screening and for indications for further imaging, A scoliometer is often used. It's determined to make an assistant need for x-rays. This, keep in mind, this assesses rotation, not the actual coronal plane sclerosis. And not all radiographic scoliosis have the rotation. Likewise, not all rotation has the radiographic scoliosis. The scoliometer to Cobb angle ratio is roughly 7 degrees scoliometer to 20 degrees of Cobb angle. So as you can see here, this scoliometer, this significant angular difference, this would be associated with a significant Cobb angle. Be aware that with a higher BMI, you're going to get a lower scoliometer reading. So it's recommended that further radiographic screening be considered if the scoliometer is greater than 7, if their BMI was below the 85th percentile. But if they have a higher BMI, then a lower threshold for screening with the scoliometer. And this is an attempt at a photograph to help demonstrate how. This is a more average, lower BMI individual with a more noticeable change compared to the higher BMI individual that essentially hides the scoliometer reading. So radiographically, initial x-ray should include a standing PA, laterals, and then subsequent lateral views are only are not necessary if the initial fails to identify a specific pathology. The curve is more common to the right, and if there's a and the left double, and the most common is a right thoracic and a left lumbar. So we all know that the actual measurement of this is the Cobb angle, and that is the intersection between the parallel to the superior plate of the most cephalad vertebrae and the inferior end plate to the most caudal vertebrae, and the intersecting angle that forms. And keep in mind here that the Cobb angle is not directly proportional to the severity. 40-degree Cobb angle is more than twice as severe as a 20-degree. And also that you're not actually either measuring the rotation with this. The radiographic exam is going to be influenced by the Risser scale, and this is just a few reminder of what that Risser scale is to help determine skeletal maturity. And as the anterior superior, the pelvic rim fuses, you advance through that Risser scale. With the issue with screening is, and there's a lot of question about this, and whether it's not actually necessary. Most curves detected through screening do not progress to needing surgical intervention. In most cases requiring surgical treatment are detected without screening. So although a systematic review found adequate evidence that bracing may slow a curve in patients with Cobb angles less than 40 to 50 degrees, evidence about the association between decreased curve during adolescence and health outcomes in adulthood is lacking. So it's really not clear that all this effort at screening is all that helpful. Untreated scoliosis does not result in substantial morbidity or mortality in most cases. And the benefit of preclinical detection is unproven. So approach to the evaluation and diagnosis, again, a nice algorithm through UpToDate, and the management. Curves progress in approximately 2/3 of skeletally immature patients before they reach skeletal maturity. And the magnitude is going to be worse. The greater risk for advancing scoliosis is if you identify them before age 12, female, premenarchal, if their initial Cobb angle is greater than 20, regardless of age, if there's a double angle, and if they're an early Risser scale. And then going on from there, when would you consider referring to a physician more comfortable managing scoliosis? That's if the scoliometer is greater than 7 in patients with a normal body mass index or less or greater than 5. If that Cobb angle is 20 to 29 degrees, in males or premenarchal females age 12 to 14, or if it's greater than 30 in any, or if you notice a progression of Cobb angle of greater than 5 degrees over any period of time. Assess the growth potential. Goes without saying, the greater growth potential, the more likely risk of advancing scoliosis. The monitoring and management is going to be based on all those things: the Risser scale, the risk of assessment of remaining growth, and the Cobb angle at presentation. Bracing is indicated in skeletally immature patients. Also, it may be considered that bracing is considered for skeletally immature whose Cobb angle is 30 to 39 at time of presentation, and skeletally immature whose Cobb angle is between 20 and 29 and progresses over a 6 to 9 month period. Kind of a soft indication for treatment here is bracing optional for those kids who are immature, Cobb angle 20 to 29, who choose bracing over observation or surgery. In other words, they may choose bracing here, even though they could be observed, or they choose a brace instead of proceeding to surgery. Lastly, of course, is surgical management, which is going to occur in a relatively small number of cases, and we'll not discuss any of the surgical management. Outcomes of scoliosis: the curves greater than 50 degrees generally progress 1 degree per year. This is later and on into adulthood now. They generally progress 1 degree per year after skeletal maturity. If they're less than 30 at the end of growth, they typically do not progress. Back pain, treated or untreated, scoliosis is associated with mild to moderate back pain. There's usually no effect on pregnancy, either in terms of affecting the pregnancy outcome, and pregnancy doesn't appear to affect the curve either. Ultimately, mortality is not increased compared with that of the general population. Okay, move on to the greater, probably hotter, more relevant topic for most of us, and that is, I've got a 14-year-old, this was one of my early cases, a 14-year-old male wrestler, low back pain for 6 weeks, no neural symptoms. What was fun about his history was his back pain began in the summer. The family obtained a trampoline. Mom said the kid would spend 1 to 2 hours per day on that trampoline, specifically doing backflips, and without hesitance referred to him that he looked like a hamster in a cage doing all these backflips. So without any surprise, his diagnosis was a pars interarticularis stress fracture. So quick, simple definitions. Spondylolysis is a defect in the pars. A listhesis is a bilateral pars defect with an anterior slip of the vertebral body. Now, I put this slide in there to just point out that most of the time in the adolescent sports world, we are dealing with the type 2 spondylolysis. But be aware, certainly talking to neurosurgeons, spine surgeons, that there are 5 other types of spondylolisthesis conditions. So in our world, in the sports young adolescent world, we're typically talking about this type 2 or Isthmic type. The prevalence, numerous studies have looked at this, and it is thought to be about 4% by age 6. And this is a number I frequently give to parents who they get diagnosed at perhaps adolescence and may or may not have had any back pain in the past. So we know that 4% of kids will have it before age 6. It's unclear if these kids have pain or if they were ever taken seriously if they did have pain. That number will go up, and depending on the studies you look at, that'll vary from 6% up to 11.5% in adults. So we know there has to be an increase of 2% or more between that childhood incidence into adulthood. And a lot of that is going to occur during the adolescent growth spurt. So many of them will be adolescents that are non-athletes, but athletics certainly brings it out. So because 38% of the athletes with low back pain will have injury to the pars interarticularis. The male-female ratio is 2-to-1, but if there is females with listhesis, they have a greater likelihood to, or with spondylolysis, they have a greater likelihood of progressing to listhesis. There's a high incidence in adult Inuits and a low incidence in African Americans. Historically, we talk about certain at-risk sports. Dance is one, gymnastics, but there's studies that have demonstrated that it may be regional. It may depend on what kind of sports you are seeing in your location. Lots of different literature on the literature on this is huge. And I want to point out this European Spine Journal in 2016 out of Japan, and make note of these names, Sakai and Sairyo. They producing a lot of literature, a lot of research in the area of spondylolysis. So in their office, 36 consecutive cases, children with spondy. These were young. They were only 9.5 years old, 23 boys, 7 girls. 90% of them had the lesions at L5. And then they were classified in stages, which I'll go into shortly. 92% of these had spina bifida occulta associated with them as well. And of those cases, they were most of these were very young individuals. They were in the cartilaginous stage of development. They're at this stage or this stage of development. Of those 30, 28 children had low back pain. 2 were identified with incidental x-rays. 25 out of the 27 L5 cases, they participated in athletic activity, baseball, soccer, and tennis. They had insidious onset low back pain. Low back pain severity would vary with training intensity. It may radiate to the buttocks. Most of the time, this condition does not. They have pain with activity that progresses to pain with ADL and rest periods. Normally, they have absent radicular symptoms and gait disturbances or other symptoms. There may or may not be a family history. I can come back to that. So with another review of these was to look at let me just look at a systematic review. They examined 617 papers to look at history with spondylolysis. And 15 papers ultimately reviewed out of these 617. They investigated the causal relationship between spondylolysis and isthmic spondylolisthesis and low back pain. Most assumed the slip or the spondylolysis was causing the low back pain. But in this review, there was no strong indication of or consistent association between the spondylolysis and spondylolisthesis and epidemiologic studies of the general adult population. So this is supporting what I learned when I was literally at the fellows stage, and that is that these findings on imaging were not responsible for the pain. And in many cases, that may be true in the adult. However, that's different in the child. Here, there was a look at a multi-site study done at Rothman in Philadelphia, Northwestern Chicago, Cleveland Clinic, 114 patients, 66 athletes who were averaging age 15 who did have low back pain for 6 months, compared to 48 non-athletes, a little bit younger, 14, but they also had back pain for 7 to 8 months. The athletes had the spondylolysis, only 2% of the non-athletes did. So a big difference in whether you were athletic or not developing spondylolysis. There was a pretty well equal distribution of disc disease, whether they are athletic or not. And in this, they also looked at the amount of degenerative change in the disc, and they call that the Fuhrman grading scale. And this is a little pictorial of the various stages of a Fuhrman grading scale for intervertebral disc degeneration. And again, for degenerative disc, the athlete, non-athlete was pretty much the same. There was in this, and this is contrary, I'm going to come back to this in a little bit. There was no difference between the athlete and non-athlete in the pelvic incidence, sacral slope, or pelvic tilt. that will challenge again. So the take-home message by these authors were that you may want to consider advanced imaging in athletes with low back pain, but advanced imaging is less beneficial in the non-athletes. So what about their exam? Their posture may be normal, maybe a hyperlordosis, range of motion may be limited due to pain, palpation over the paraspinal muscles, there might be some tenderness. If you have a significant listhesis, you might detect a spinous process step off, hamstring tightness, neurologic exam, pain with extension, and then we'll talk about the Stork test. This was a review here that demonstrated that ultimately that the Stork test was not that helpful. One-legged hyperextension Stork test, the sensitivity only 50 to 73%, and the specificity 17 to 32%. So you're going to have back pain for a lot of other reasons. Do the Stork test and have a positive test. So we seem to do it routinely, but in terms of clinical decision making, it's not all that helpful. So we got to move on to imaging and when to pursue a workup. This was a yet to be published, or it's published ahead of print study that is looking at 223 junior high students with low back pain. That patient profile is most likely to have a positive MRI, males greater than females, and that they have presented within 32 days of symptom onset, and their sports participation is greater than 72 hours. So that's kind of the profile that I would frequently use. If there's pain for more than a month, start imaging. And this is just demonstrating that generally 2 views are equivalent to 4. So for radiation concerns, you may consider just doing 2 views rather than 4. The AP, you're looking for spina bifida occulta and other conditions you might pick up on the AP view. Standing lateral is helpful. I do all of the laterals standing, so you get an appreciation of the lumbosacral relationships. Now, going on to the advanced imaging with this spine review here, 13 studies reviewed the advanced imaging indications and what you would find. 10 studies looked at the sensitivity and calculations. The MRI versus the CT was 81%, and that's a number that was has been frequently thrown out. You're going to miss still 19% of cases with MRI. The CT is positive. When they compare it to CT, they're looking at old cases. So this is an MRI compared to terminal cases of spondies. The CT compared to the SPECT scan is 85%. The CT scan will be negative if the case is very early. You may have a positive SPECT, but a negative CT if you catch it early, just like you would any other bone stress fracture. The MR versus the SPECT. This was the highly quoted standard of care for a long time, and that is 80% positivity, sensitivity. So we would miss 20% of the early spondies based on MRI compared to SPECT. And so the MRI is clearly superior to CT in early lesions. So there's pros and cons to both MRI and to SPECT. The majority of studies recommend MRI as initial advanced imaging study, and some advocate follow-up CT in equivalent situations, and I do that quite frequently. Knowing that I might be in that 20% false negative category. And that's exactly what the concern was. Studies not recommended MRI was concerned about the false negatives. This is just showing that our concerns for doing the radiation. If you choose to do a bone scan, which is my last choice nowadays, you're increasing the amount of radiation to these young people. Now, with SPECT and bone scanning, I want to make a point. This was a Lyle McKelly paper in a long time ago, 1991, showing that the imaging has to be done by SPECT. If you did planar bone imaging, and this has happened to me numerous times from outside sources, where they will do a planar bone imaging, that will be appear to be normal. When in fact, if you do then the specs CT cutting, then you'll see the abnormality that was not appreciated on planar imaging. So you miss a lot of them. If you choose to do radio tracer studies, it has to be specced. Structural contributors to spondylolysis here. And spina bifida is the big one. I can see I'm going to be rushing here a little bit. And this, I'm going to go back to that sacral slope here. This was a biomechanical study that was looking at the stresses at the pars with the increasing pelvic incidence, showing that as that with greater sacral slope, greater pelvic incidence, there's greater pars stresses. Another is the orientation of the facets, and I've looked at this for years with a CT scan. The key incidence here is that we're not always symmetric, and the facet orientation changes as you go from the thoracic down into the lumbar spine. The facets are more horizontal; they're more in the coronal plane in the thoracic vertebrae, and they become more sagittal in the lumbar vertebrae. So it allows for greater sagittal plane motion. So the alpha angle here off of a sagittal line is this, and that the greater that, the less that alpha angle, the more sagittal plane motion that individual will be able to do. The other one is asymmetry, and I've also noticed this over the years, that the two sides are not the same. So that's the beta here, the tropism. So if there's a big difference between the two, then you're going to have asymmetric motion at the spine. So adult spondy is associated with a greater alpha angle or a greater sagittal angle, and it's also with a greater asymmetry. The worse this is more likely they're going to have spondies. And this is just going through all the detail. Another point is that it's thought that the spondies may be associated with a smaller vertebral size. Smaller cross-sectional area of the lumbar vertebrae may be associated with increasing spondies. And I'm just going to move on from that. This is a board type of question that may show up, just to be aware that with advanced spondylolisthesis, the classic X-ray imaging is the Napoleon sign, the upside down Napoleon's hat on an AP view. Goals of treatment. We're going to get pain relief, rehabilitation, return to sport, and then ultimately long-term risk reduction. Pain relief, elimination of sport, and rest. That's controversial and is variable. And rehabilitation is not controversial. Work hard on hamstring flexibility and core strength. This is a recent study looking at rehabilitation and indicating that the sooner we got these people into PT was the quicker we got them back to sport. So the aggressive group here, meaning they got into PT relatively earlier, returned to sport several days, 25 days faster than those who had delayed PT. Bracing is very controversial, and I'm not here to answer that question. Ultimately, it seems like you can find literature to support your opinion, whatever that opinion is. Some strongly in favor, some and not. The study, there's a lot of heterogeneity in the studies. There's definition of treatment success varies. There's a large diversity of the lesion at presentation. Do they actually use it? Do they rest comply it, etc.? So the Sairyo, again, out of that Japan office, recently looked at a brace effect on staging and timing. The purpose of this study demonstrated that was if you caught these kids at an early stage, in this stage rather than in this stage, then you had a much greater chance of actually getting bony healing. And this was his data. These were early defects that had positive MRI, and their union rates were much greater if you caught them in their early stages compared to MRI negative or in the terminal stages. Sairyo, and this is also just very recently, well, I'm sorry, that's just going on from there. Ultimately, Sairyo also looked 2017 in spine at 63 patients, imaging, MRI, CT, multi-detector. If you caught them at a very early stage where they had a stress reaction on MRI, but no fracture line on CT, they ultimately had a better chance. All I do is move my mouse and it changes. They have a better chance of good healing. So I'm going to advance through that. I have a couple of other things. These are ultimately the key points. Bony healing rates for pediatric spondylolysis showed higher bone healing and shorter treatment periods than reported previously. In the very early stage, the bone healing rate is 100%, and the average treatment period 1 to 7 months. So that's available. I'm not going to read through all of those. I do want to. This was one case that I had. All 3 boys in the same family had spondies. This mom was a PT. She actually insisted on the brace, and then the child had absolutely no choice but to follow mom's PT. And so all these boys ended up playing baseball, and they were pitchers, learned how to pitch with a brace. All of them got bony healing and ultimately played in college and one minor league baseball pitcher. I'm going to skip this. That's only further corroborating the controversies. I want to mention real quick a couple of other things. Upper thoracic back pain in a golfer. This is just other things to consider. And this is a case we had here several years ago, and this was a rib stress fracture in a golfer that presented with thoracic back pain. Also in the thoracic back pain of an adolescent is the possibility of an apophyseal fracture. There's growth plates at the tip of the transverse processes, so keep this in mind for paraspinal thoracic pain, usually of abrupt onset. Can be very hard to see on MRI if that cut doesn't go right straight through there. This is one of those where I may favor bone scan to pick it up. So apophyseal fracture as a possibility for thoracic back pain. A case of mine, a 16-year-old dancer decided to try pole vault, developed low back pain, midline low back pain, worse with any kind of extension. Her problem then was this. She had soft tissue edema between the spinous processes, between L4 and 5. And this is Baastrup's disease. The classic Baastrup's is an elderly condition with kissing spines. In the young adolescent with a lot of back extension flexibility, and get soft tissue contusion between the spinous processes. So keep that in mind as a possibility. Repetitive extensions, greater flexibility, and the gymnasts are the most common. Bertolotti's is also something to consider, and that's the lumbosacral transitional vertebrae. I had a number of these cases over the years where you have some sacralization of lumbar transverse processes. Again, maybe this may be hidden by the pictures. Various stages of this, and be aware of that as a potential source for low back pain. And lastly, other things to think about are sacral stress fractures, osteoid osteomas causing low back pain. And a recent case I had was on AMSSM this year, which is a case of a swimmer with a Ewing sarcoma. So I rushed through the latter part because I spent too much time in the middle, but I will stop now for a couple of minutes of questions.
Thank you. That was great. I don't see any questions yet, but I have a question for you. I actually always reach out to my younger colleagues that had just finished fellowship and ask them if they have any questions, because I expect always to have to ask a question, just with some silence in the chat. And they actually were the two same questions today: protocols on imaging for concern in an adolescent athlete with low back pain, concern for, pars defect. What's your typical time frame, and what do you typically do with that imaging protocol?
Yeah, the first is just physician judgment, that anybody would have, get a sense of this youngster. How much pain are they having? Is it significant? How is it affecting them, et cetera? All that kind of general stuff first. But if once you get that sense that they are legitimately having low back pain, teenagers should not have chronic back pain. So again, I know that I was influenced by McKelly some 30 years ago. And so if that back pain is lasting longer than a month, and is usually non-radicular, although radicular raises the possibility of discs, and teenagers should not be having discs, at least in large numbers, but usually without radicular symptoms, in a high risk or any kind of risky sport. If they are in that profile, then I will start to get the imaging at about a month. And whether or not I let them play sport during that month is up to a general sense of their level of pain, what sport they're doing, can they do it. I generally tell parents and the athletes, I don't think we're going to cause any irreparable harm by allowing that sport to keep going for another couple of weeks. But if it's still there, then we'll start the imaging.
Okay. And so you start with an X-ray. If that's normal, do you then immediately follow up with MRI, or
yes,
do you wait a short period of time before you would advance?
Yes. If you get that X-ray, the dilemma is if you get the X-ray and they have a mature spondy or a listhesis, and you now know that there is potentially an explanation for the pain, you may choose not to go on to that advanced imaging because you seemingly have an answer. Now, a caveat with that is that I have had athletes who have had fresh spondies at multiple levels. And I can specifically think of a high school quarterback who had simultaneously had bilateral spondies at L4 and L5, so 4 stress injuries. And so the risk you take if you choose not to do advanced imaging is that the mature spondies that you have may be asymptomatic and old, and you're missing a new either on the opposite side, and that's often an issue. You might see a mature spondy on one side, but the patient's complaining of their pain on the contralateral side. I pretty quickly then go on to an MRI. I would like to identify, for the reasons that was stated here, I would like to identify these things early if possible. The potential for bone healing, whether you use a brace or not, the potential for bone healing is greater if you catch them at a younger age, at an earlier stage.
Right. Okay. Let me see. No questions in the chat. I'll follow it up with another. While you're getting that advanced imaging at that point, now a month in or a little beyond, while you're getting the imaging, what do you typically do with the sport?
Again, that might be community dependent. I think I can get my MRI within a week. If they don't have any red flags and not neurologic, I will continue to allow them to participate. I always send them out the door. We may change that after we get the test back, but I usually let them continue to participate until I have that test back. And then if I've got signs of a fresh and a positive MRI, or if we've chosen to do a positive bone scan, at that point I will stop them.
Okay. And then what would be your protocol?
Then we have this. I have this discussion about the controversy: brace, no brace. And again, it may go back to what's the age of the athlete, and what stage it's in. I'm a little more persuasive if they're young. Obviously, I really, as before, if they're at that immature chondral stage of development, and they're 13, 14 years old, I would be more aggressive about withdrawing the sport, and then talking about bracing them at that age. At the older ages, probably less, we have a conversation about it, but I don't push them in that direction at all. Or of course, if they appear to be further along in this stage, if they're certainly in that terminal or bone MRI negative but CT positive, then no, there's not going to be any benefit from that restriction. And I'll use this as an opportunity to say why I'm passionate about the difference in the bracing. And that is, most of the brace studies have been done in older individuals. They've been done on post-surgical patients, and they lack that opportunity or that recognition that a young athlete's back can go into tremendous extension. So even though some studies may show the back brace doesn't stop it, I find that hard to believe that it can't stop a young teenager from 45 degrees of back extension that the adult would never get into anyway. So that back brace, if not a mechanical restriction, gives them a reminder, a tactile reminder to stop that extreme extension. So in that case, they inevitably would seem to have less stress on the pars. Whether or not you can actually say they get bone healing. The last part about that for me is that I've been much more permissive in allowing them to return to sport quicker, and then follow them for bone healing, which I don't, that was the data that I skipped over, as that bone healing, I think, has been as good returning to sport earlier in a brace.
Okay. If you have a negative MRI, what CT specific test will you get? Spec lumbar CT, a focused lumbar CT?
Yeah, that's a tough one. My first fear is that am I in that 20% of a false negative? There was a study done also in Japan showing that a key parts of the MRI is to have stir imaging both in the sagittal and the axial plane. Most of the MRIs, if you don't specifically ask for it, will give you a stir in only one plane. So it's possible, and usually you see the edema in the pedicle, and it's possible to skip over the edema in subtle cases, particularly if you only have that stir in one plane. If you have it in both planes, you increase your chances of picking it up. I don't have an answer to that sensitivity, but I followed these for a long time, and I continued to have people who had a negative MRI, continued pain. I then chose to do the bone scan. And a small number of cases have had a positive bone scan, negative MRI. And then with the positive bone scan in a typical pedicle, or rather typical pars location, I will CT, but we've got our departments here clued in that we restrict the CT to that level of the positive bone scan only. They do not do an entire lumbar spine CT, only L5, for instance, if that's where it's positive.
Okay. I have a couple questions in the chat if you have time for them.
Sure.
One comes from Jordan. She says, can you touch on follow-up imaging versus symptomatic return once you have a confirmed spondy and the athlete has completed a rest period? That's question one. And then repeat image versus progress based on symptoms.
Yeah, there's not a clear answer to that. And it's confounded by both academic curiosity, individual curiosity, parent curiosity. it would be reasonable to follow strictly clinically and allow them to return based on their symptoms. It's not uncommon, both from my own perspective academically. Did we get bone healing? If they were in that early stage, and these are the ones as in Sairyo's article there that are early, then a follow-up CT. All of those studies were based on repeat CTs done at 2-month intervals. And so that follow-up CT may be helpful in saying that this is now bony healed and return to sport unrestricted versus strictly the clinical follow-up. Parents may be interested in knowing. We also are, unfortunately, we learn from occasional anecdotes. And I had one of those baseball players that I mentioned. All 3 boys had spondies. One of them had a fresh pars stress fracture on one. While he was in the brace, he developed a new stress fracture on the other side. Ultimately, he got bony healing after 9 months. And had we followed him clinically only, I fear that we would have pulled him and returned him to sport a bit prematurely while he had developed a new stress fracture on the other side. To this date, I don't have an explanation why, other than he was so early in the contralateral stress fracture that we didn't have it, it didn't pick it up. On the other hand, he could have been non-compliant and out there throwing a baseball, despite our recommendations to slow down.
Right.
So judgment call, and I usually employ the parent's opinion with that decision on follow-up imaging.
Okay. And then switch gears completely. Another question from Gabby. If there is a necessity for surgical intervention for correction of idiopathic scoliosis, what is the return to play protocol post-surgery?
Oh boy, I don't have an answer for that. I purposely avoided that. Like I said at the beginning of scoliosis, you could easily have one of these sessions devoted strictly to scoliosis, which would go on into all the post-surgical management. And as a practical matter, I've not been in a position to make return to play decisions post-surgical. That's been up to the spine surgeons. Good question. Don't have an answer for you.
Okay. Thank you. I asked several questions. I think that's all in the chat for now. Thank you so much. That lecture was awesome. Had a lot of great information. It's okay. We went a little over. I think it was well worth all of our time.
Okay. Hopefully everybody got a good nap.
Thank you.
All right. Bye now.
Take care.